Welcome to an introduction to the diagnosis and management of primary brain tumors. My name is Nick Gonzalez Castro. I'm a neuro-oncologist at the Dana-Farber Cancer Institute and an associate neurologist at the Brigham and Women's Hospital, both in Boston. These are my disclosures. None of them are relevant to the content of the presentation. I want to start by discussing briefly the epidemiology of primary brain tumors. I note that brain metastases and primary CNS lymphoma will be discussed in a separate talk within this program. The incidence of primary brain tumors increases with age and accounts for about 45 per 100,000 in adults older than 40, about 11 cases per 100,000 in individuals between 15 and 39, and approximately 6 cases per 100,000 in children and young adolescents. I note that in children and in infants, primary brain tumors are the most common cause of cancer and the most common cause of cancer death. These are some plots that show us the distribution of different cancers for different ages. And as I was mentioning, for the young, brain and CNS tumors are the most common, followed by leukemia. For the young adult population, brain and CNS tumors moves down to the third place. And then in older individuals, brain and CNS tumors are not as common as other cancers become more incident, such as lung cancer, prostate cancer, and breast cancer. When we look at brain tumors by themselves, primary brain tumors, there is a breakdown between malignant brain tumors, those that are thought to grow in a somewhat indolent fashion and be completely cured with a complete resection, including meningiomas and some nerve sheath tumors, and malignant tumors that tend to infiltrate the brain and other CNS structures and are not cured by surgical resection and invariably progress and lead to death. When we look at the incidence of brain tumors in the young, we see a relatively stable pattern for most primary brain tumors, with an increase only in tumors of the pituitary as individuals age. While when we look at adults 20 and older, we see slow increase in the incidence of most brain tumors and a marked increase in the incidence of meningioma as individuals age. When we take a look at all malignant brain tumors, we see a slight male predominance. However, when we looked at brain tumors in the aggregate, both malignant and non-malignant, there is a slight predominance of female cases because meningiomas, which are the most common brain tumors, and most of them are grade 1 and happen to be non-malignant, are more common in women. I want to mention briefly brain metastases, despite the fact that this will be discussed separately, but approximately 10 to 30% of patients with systemic cancers will go on to develop brain metastases. And in all, they're the most common type of brain tumor. There are 10 to 1 incidence of brain metastasis compared to primary brain tumors. And as known, the most common histologies are lung, breast, melanoma, colon, and renal cell carcinoma. It is often asked of neuro-oncologists and neurologists and other practitioners about brain tumor risk factors. And it's important to clarify to patients that the only demonstrated risk factor is high dose therapeutic ionizing radiation to the CNS, such as whole brain radiation that is given for some childhood hematologic malignancies to try to remove any potential leukemic cells. So only at the ionizing high frequency range of the spectrum is that we see over time a higher incidence of brain tumors. There are no strong data to support radiation, electromagnetic radiation from cell phones or power lines or TV or other electronic appliances as leading to the development of primary brain tumors. There are, however, other factors that can come into play. Immune system status is thought to be somewhat correlated with the development of some brain tumors, such as CNS lymphoma, which is more common in patients that are immunosuppressed, such as those with acute acquired immunodeficiency syndrome, patients that have received transplants and are on long-term immunosuppressions or organ transplants, or patients that are on immunosuppression over a long period of time for other inflammatory conditions. There are some hereditary risk factors that lead to brain tumors, although these account in aggregate for less than 5% of brain tumor cases. And I'll highlight Lee-Fraumeni syndrome with mutations in p53, neurofibromatosis type 1, mutations in NF1, neurofibromatosis type 2, mutations in NF2, the von Hippel-Lindau syndrome with mutations in the VHL gene, Turcot syndromes with mutations in APC, and Gorley syndrome with mutations in patch1. This can lead to malignant gliomas in the case of Lee-Fraumeni, optic nerve gliomas or optic tract gliomas in NF1, acoustic neuromas and meningiomas in NF2, hemangioblastomas in von Hippel-Lindau, glioblastoma and medulloblastoma in Turcot syndrome, and medulloblastoma in Gorlin syndrome. The clinical presentation of brain tumors often is with seizures. However, it's important to note that only 5% of patients with new onset seizures are found to have a brain tumor. Seizures are more common in primary brain tumors than in metastases. And there's a higher prevalence of seizures as a presenting sign for low-grade gliomas compared to glioblastoma. This is thought to be due to oligodendrogliomas and some IDH mutant diffuse astrocytomas infiltrating and affecting cortical structures, hence leading to seizure. Brain metastasis can also present with seizures, but at a lower rate. And I note that prophylaxis with anti-epileptic drugs is not indicated in patients with primary brain tumors or those with brain metastasis that have not had a seizure. There are some emerging data that might suggest that these might be warranted in patients with melanoma brain metastasis, which are often hemorrhagic and very inflammatory, and there might be a benefit there, but it's still not a recommendation of all the neurologic and oncologic societies. Headache sometimes can occur as the presenting symptom of a brain tumor, and this happens in about 35% of patients. And up to 70% of patients develop headache during the course of the disease. Headaches are usually dull, bilateral, constant, and usually worse in the morning when patients wake up. The headache is exacerbated by coughing or Valsalva, which suggests increased intracranial pressure. It's always recommended to do a fundoscopic exam of these patients to try to evaluate for blurring of the optic disc margins, which might suggest increased intracranial pressure. Nausea can also be present due to the effect of increased intracranial pressure in the area postrema, in the dorsal medulla or floor of the fourth ventricle. And I also want to highlight for non-neuro-oncology and non-neurology practitioners that the vast majority of headaches seen in the general population are primary headaches, such as tension headache, migraine headache. So it's important to reassure most patients. However, if a patient presents with a new onset headache with the above features, imaging with brain MRI is always warranted to evaluate for brain occupying lesion. a space-occupying lesion of the brain. Syncope can be a presentation of a primary brain tumor, often in the setting of increased intracranial pressure that happens transiently, leading to so-called plateau waves, where patients lose consciousness, have an acute headache, and then they lose consciousness. Cognitive dysfunction is sometimes seen, most commonly with primary CNS lymphoma affecting the frontal lobes. Memory dysfunction is also seen in patients with temporal lobe tumors, often in the setting of seizures. These are focal seizures that are affecting memory formation and memory consolidation circuits, and patients, when they're connected to EEG, they're noted to be having seizures, although there are no other aspects of the semiology that might suggest to an external observer that the patient is having seizures. Focal deficits such as weakness, sensory changes, aphasia, and vision changes are often seen. Hemianopsia with occipital tumors, bitemporal hemianopsia with pituitary tumors. The focal deficits are often subacute, and when the presentation is acute, this is most likely in the setting of seizure or intratumoral hemorrhage. Other diagnoses to take into consideration when evaluating a patient for a brain mass, one is a primary CNS tumor such as glioma, meningioma, primary CNS lymphoma, pituitary adenoma. Brain metastases are considered based on location, the appearance of the lesions, the number of lesions, a history of systemic malignancy. Inflammatory diseases such as demyelinating disease, such as multiple sclerosis, neuromyelitis optica spectrum disorder, sarcoidosis and IgG4 disease should also be considered, as often these will present with brain or lesions in the meninges. Infection such as a brain abscess, toxoplasmosis, particularly in patients that are HIV positive, tuberculoma, or lesions from neurocysticercosis should also be considered. Or vascular lesions, such as an intraparenchymal hemorrhage, an arteriovenous malformation, a cavernous malformation, or a subacute infarct. The diagnostic evaluation of patients with primary brain tumors begins with imaging. And the most sensitive study is MRI with gadolinium. MR spectroscopy is often obtained to try to characterize the lesion at a metabolic level. And some clues of a lesion representing a tumor include an elevated choline to creatinine ratio and a low N-acetyl aspartate peak, or NAA peak. A CT of the chest, abdomen, and pelvis, or a PET are obtained in selected cases where we think that there could be a systemic malignancy underlying the brain lesion, or in cases of primary CNS lymphoma when we want to do an evaluation for extent of disease. Serum studies are also often obtained, but this is just to rule out other conditions in the differential diagnosis, such as infectious or inflammatory conditions. CSF studies, which should only be obtained after brain imaging to ensure that it will be safe to perform a lumbar puncture, are needed for lymphoma, leptomeningeal metastases, posterior fossa, and pineal tumors, which have frequent CSF spread. On testing, we should send the usual tests: cell count, glucose protein, as well as cytology, flow cytometry, and IgH gene rearrangement if we're concerned about primary CNS lymphoma. Cytology for many brain tumors that have CSF spread can be negative on the first lumbar puncture, with a sensitivity of only about 71%, but the sensitivity increases with additional lumbar punctures. So these are often repeated to try to increase the sensitivity of the test. The definitive diagnosis is a tissue diagnosis, which is done through a biopsy for primary CNS lymphoma, or for brainstem lesions where complete resection is not possible. But in hemispheric lesion or posterior, some other posterior fossa lesions, such as cerebellar lesions, a maximal safe resection is performed. This is a resection where most of the brain lesion as is seen on the MRI, particularly the enhancing portion of the lesion, if it's an enhancing lesion, is resected. And this is only done without trying to be so aggressive so as to cause deficits in the patient. So that's why we call it a maximal safe resection. It is indicated to leave, tissue from the lesion behind if, removing it would lead to a permanent deficit on the patient. The classification of the central nervous system tumors is done by the World Health Organization, and last year, the most recent edition, the 5th edition, was just published. It's a very comprehensive and detailed classification that includes more than 120 types of brain tumors. I know that all cell lineages in the CNS can undergo malignant transformation, but it is most commonly seen in glial cells and meningothelial cells. And each diagnosis in the WHO classification relies both on aspects of histology as well as molecular alterations that are determined in the tissue sample. In addition to the classification that gets published every several years, there are updates that are published every few years, trying to add clarity or streamline the classification of some of these tumors. And neuro-oncologists in particular should be aware of these updates on the diagnostic criteria for different tumors. I want to talk about gliomas now, which are the most common malignant brain tumors. They account for 26% of all primary CNS tumors and 81% of malignant tumors. And the classification of astrocytic and oligodendrogliomas is based on the presence of mutations in a protein called isocitrate dehydrogenase, or IDH, as well as co-deletion of chromosomes 1p and 19q. So we talk about IDH mutant gliomas and IDH wild-type gliomas. IDH mutant gliomas include diffuse astrocytoma, IDH mutant, grades 2 and 4, or oligodendroglioma, which in addition to an IDH mutation also has a 1p19q co-deletion, and this can be grades 2 and 3. And then there is glioblastoma, which is the most common and aggressive malignant primary brain tumor, which is always a grade 4 tumor. Glioblastoma has a median age at diagnosis of 65 years. On imaging, they're peripherally enhancing with central necrosis and hemorrhage. Histologically, they demonstrate high cellularity, multiple mitotic figures, areas of necrosis and microvascular proliferation. Molecularly, they do not have mutations in IDH. They often show gain of chromosome 7 associated with EGFR amplification, which is a driver, loss of chromosome 10 with loss of P10 tumor suppressor gene, and MGMT promoter methylation in about 40% of cases. MGMT promoter methylation is thought to be associated with a better response to alkylating chemotherapy such as temozolomide. In terms of treatment, as this is an invariably fatal tumor, the National Comprehensive Cancer Center guidelines recommend a clinical trial as the first option to try to improve survival of patients. But if a clinical trial is not available, the standard of care includes maximal safe resection, radiation with temozolomide, followed by adjuvant temozolomide, and the addition of tumor treating fields, which is an external device that generates an alternating electric field that disrupts the mitotic spindle of dividing cells and helps slow down tumor growth. This is a treatment that was FDA approved approximately 5 years ago, and a number of patients decide to use during their cycles of adjuvant temozolomide. The prognosis is 16 months on average for patients that have a unmethylation of the MGMT promoter, and 22 months for those patients that have methylation of the MGMT promoter. Diffuse astrocytoma IDH mutant is the second most common primary brain tumor. The median age at diagnosis is 36. Imaging characteristics include hyperintensity on T2 weighted images, and these are often non-enhancing, particularly grade 2. On histology, there's increased cellularity, multiple mitotic figures. They could be necrosis or microvascular proliferation, but only if grades are 3 or 4. Molecularly, they have IDH mutations, loss of ATRX. Chromosomes 1p and 19q are not co-deleted as such as in oligodendroglioma, and there's often loss of CDKN2A or V, which indicates that the tumor is a grade 4. This molecular feature by itself can upgrade the grading of a tumor to grade 4. Clinical trials are also the first option. And for standard therapy, we recommend maximal safe resection of all the T2 flare hyperintense areas and additional treatments that depend on the extent of the resection, the grade, and the age of the patient. The median overall survival for grades 2 and 3 is 8 to 12 years. And for grade 4 is 24 to 48 months. Oligodendroglioma is the other IDH mutant glioma. The median age at diagnosis is slightly older, approximately 40 years of age. On imaging, they're similar to astrocytomas. They're T2 hyperintense and often non-enhancing, but they often demonstrate SWI signal due to calcifications in the tumor. On histology, they have this fried egg appearance, which is the result of affixing artifacts, as well as branching vessels called chicken wire and calcifications. Molecularly, these have IDH mutations and co-deletion of chromosome 1p and 19q, as well as very frequently TERT promoter mutations. Clinical trials are also recommended as the first option of treatment here. And standard therapy includes maximal safe resection of all T2 hyperintense areas. And as in the previous tumor, additional treatments depends on the extent of resection, grade, and age of the patient. There are 2 different chemotherapies that have been considered for the treatment of this and diffuse astrocytoma IDH mutant, including procarbazine, CCNU, and vincristine, which is an older regimen that has been validated in clinical trials, as well as temozolomide, which is what we use for glioblastoma, which is better tolerated, but it's currently undergoing evaluation in terms of its efficacy as compared to the PCV regimen. The prognosis for oligodendrogliomas for grade 2 is 10 to 15 years, and for grade 3 is 3 to 6 years. Meningioma, as I mentioned earlier, is the most common primary brain tumor. And as I mentioned earlier, is in most cases benign brain tumor. The median age of diagnosis is 65. They're more common in women. They're extraaxial lesions that are homogeneously enhancing. On histology, they show whorls of tumor cells, as well as samoma bodies that represent calcifications. Molecularly, they often show progesterone staining, somatostatin staining, as well as NF2 mutations or deletions. About 85 to 90% of them are grade 1, which are cured by gross total resection. Grade 2 tumors undergo gross total resection, and radiotherapy is often added if there's residual. And for a grade 3 tumor, there's gross total resection and radiation. And these are tumors that are often recurrent and very difficult to treat. The prognosis is greater than 10 years for grade 1 tumors, 2 to 10 years for grade 2 tumors, and less than 2 years for grade 3 tumors. Note how aggressive the grade 3 tumors are. Pituitary adenomas are often seen in patients, and most commonly, they're seen in women that are younger than 40 and men that are younger than 50. On imaging, they're T1 iso intense to the brain tissue and have delayed contrast uptake compared to the gland. They're called microadenomas if they're less than 1 centimeter, or macroadenomas if they're greater than 1 centimeter. On pathology, they demonstrate adenoma histology, classified according to the hormonal products, if it's a secreting adenoma. For evaluation, we check insulin-like growth factor 1, IGF-1, growth hormone, thyroid function tests, follicle stimulating hormone, luteinizing hormone, testosterone, estrogen, cortisol, corticotropin, electrolytes, and glucose, not only to understand, what the tumor is secreting, but also to understand if any of the other hormones in the HPA axis have been affected. Urine electrolytes and 24-hour urine-free cortisol and dexamethasone suppression test is done for Cushing test. In terms of treatment, the recommendation is for surgical resection, transphenoidal is possible. But I know that in prolactinomas, these are, in most cases, in the vast majority of cases, very responsive to treatment with dopamine agonists such as cabergoline, and those patients do very well when they're started on that treatment. The prognosis depends on the size of the tumor and the cell type. There's a 70 to 90% remission rate 1 year after resection, and 95% of prolactinomas are well controlled with dopamine agonists. We have had a discussion now of the clinical presentation, the diagnosis, and the management of all the most common primary brain tumors. These are references that the readers and the users of this program can go back to for additional information. Thank you for your time.